Committee on Health and Welfare. This is our first meeting of the session. The date is Wednesday, January the 12th, 2022. Madam Clerk, please call the roll.
Senator Rocky Adams. Senator Berg. Senator Carroll.
Present remotely from my district.
Senator Givens. Senator Harper Angel. Senator Howell.
Present in the room.
Senator Kerr. Senator Nemes.
Present in the room.
Senator Wise.
Present in the room.
Vice Chair Meredith. Present. Chairman Alvarado.
I'm also present. We have a quorum and we're constituted to do business. First thing we're going to do is address our consideration of referred administrative regulations. I think hopefully all the members have had these in advance, had a chance to review them. I've reviewed them, don't have any particular concerns. I know we do have one agency amendment on one regulation. If you take a look at 902 KAR 002020, I don't know if Ms. Julie Brooks or if Dr. Stack are online. And I was hoping, hopefully you're there. If you guys could introduce yourselves and just briefly explain the amendment and what it does for the committee.
Sure. Thank you, Mr. Chair. So Julie Brooks is our Director of Regulatory Affairs over here in Kentucky Department for Public Health. This regulation, the big regulation, is our reportable disease regulation. And we were doing regular housekeeping updates to it last year, and it was coming here today for its second reading to the committee. With the surge in the Omicron cases in the outpatient setting, the burden of reporting disease reports for all the patients in the outpatient setting is overly burdensome. And this second reading allows us the opportunity to remove that burden from offices and emergency departments in the outpatient setting. We will still get the laboratory results, which is all we really have to have from that setting at this point. And we will remove the burden of reporting requirement from them to have to submit the longer 2-page clinical case report form unless somebody is admitted to the hospital, so the sickest patients, or someone dies from COVID. So we are curtailing the amount of burden of reporting that the outpatient setting has to comply with. We've talked with the Hospital Association and the Medical Association, and I believe they're also supportive of this.
Thank you very much. That's always helpful to deburden our providers, particularly right now, as things are obviously very stressful, so we appreciate that. Any questions from the members of the committee regarding that amendment or really any of the regulations that are before us? If not, we'll need to take action on that amendment. We need a motion. So moved. We have a motion. Is there a second? Second. You have a second? All those in favor signify by saying aye. 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 Any opposed? All right, so the amendment is approved. And let the record show that all of these regulations have been reviewed. Dr. Stack, thank you so much. We appreciate your time and the explanation.
Thank you, Mr. Chair. Have a good day.
All right. We have three bills for consideration today. The first is Senate Bill 11. This is an act relating to long-term care facilities. I am the sponsor, so I'm going to come down to the table there, and we have several individuals who also are here to help present on the bill. They'll introduce themselves as they present testimony. I want to remind all members this is a bill that was presented during the interim, so we all had a chance to hear a presentation. I think I wasn't here when that was done. So it is now Senate Bill 11, and there is a substitute that we'll be taking action on as well. I'm going to turn the gavel over to my Vice Chairman.
Thank you, Chair Alvarado. If you would, sir, please introduce yourself for the record and your guest, and please proceed.
Thank you. I'm Ralph Alvarado, State Senator for the 28th District. If you guys want to all introduce yourselves to the record.
I'm Tim Vino. I'm the president of Leading Age Kentucky.
I'm Mark. Living and licensed personal care. Additionally, I work closely with coalition partners in the Senator in putting this bill together.
I'm Bob White. I'm Executive Director of the Kentucky Senior Living Association.
I am Betsy Johnson. My mask is caught in my earring. I figured that out. I'm Betsy Johnson, the president of the Kentucky Association of Healthcare Facilities.
Appreciate all of you being here this morning. And Senator Alvarado, if you would, please proceed.
Thank you, Mr. Chairman, members of the committee. I'm pleased to present Senate Bill 11. This is a bill that's been worked on for the past 2 years. It's required the collaboration of multiple medical providers and has received the input of several different patient advocacy groups. This is a bill that was, again, presented, like I mentioned earlier, in my absence during the interim for discussion. The purpose of the bill really is to modernize Kentucky's assisted living social model to align more closely with the vast majority of states.
Senator, I hate to interrupt your presentation, but you do have a sub on this.
Yes.
Would you like to proceed with that first?
Sure, I'll be happy to do that.
There's a motion on sub. Is there a second? Motion and second. All those in favor say aye.
Aye.
All right. Thank you. Please proceed.
Thank you so much. So, to that end, the bill was pre-filed to allow review and input from multiple agencies and has been in the public sphere for several months. On the Senate committee sub that is now before us, and there's kind of some succinct highlights to that sub as well. But I thought instead of hearing me discuss this, I think we've got some experts in the field who can go through it. I preferred a lot of remarks, but I think it might be better in the interest of time if we let Mr. Lee talk about a little bit about what the substitute does. Again, we've heard details of the original bill, so a lot of these are changes that have been made from a lot of the input from different providers. So, Mr. Lee, if you'd like to go over some of the changes to the in the sub.
Thank you, Mr. Chairman, and thank you to Vice Chairman and the members of the committee for the opportunity to meet with you in the run-up to this this meeting today, and the ability and the opportunity to testify. Again, to highlight the changes that are in this committee sub. It has brought assisted living into the jurisdiction of the Ombudsman for the first time. And when I say the first time, the initial mandatory assisted living statute was passed, as you know, in 2000. And neither the Ombudsman nor Resident Rights Statute 216-515 have applied in those 22 years now to assisted living. And we listened. We listened during that October 20 interim joint committee meeting to questions and comments from the members and also advocacy groups and the cabinet since then. And we thought it made sense to take that step regarding ombudsman and resident rights. And the reason resident rights wasn't applicable before in assisted living, it was in personal care setting. It wasn't in assisted living, and that's because as a social model all these years, it has been subject to landlord-tenant laws and leases. That relationship will still be there. That protection will still be there. But when we heard concerns about why not include that long list of resident rights and make it applicable to all assisted living residents, we said, okay, let's do that. So we're expanding protection by making the statutory rights applicable to assisted living residents for the first time. Numerous additional changes that respond to concerns raised by the Alzheimer's Association have been made. Most of those have been focused on strengthening Alzheimer's-specific staff training. I will say that we are aware of only one additional issue with the Alzheimer's Association that they have with the bill. My understanding is that it relates to the process of licensure of buildings with a relicensure, if you will, under this new statute of existing providers with dementia care units. And but the bill does clarify that the cabinet will conduct a complete initial licensure survey before licensing a new applicant with a dementia care unit. But it does differentiate the process and make it somewhat more abbreviated for a provider that's already been operating with the blessing of the state, if you will, with certification as an assisted living provider or a licensed personal care provider. We frankly thought that was a matter of due process and just made good sense. A couple of changes were requested by the Hospice Association, and we were successful in working out language that satisfied them and worked well. Multiple changes were made that respond to some concerns raised by the Cabinet for Health and Family Services. And included in those are making the duration between relicensure surveys 12 months if there have been serious violations in the previous survey cycle. Serious violations that affected or potentially affected health and welfare of residents. 24 months, though, would be the duration under this committee sub if there was what I will characterize as a good previous survey, ones where there weren't serious violations, where they were more, we missed a date on this, where it was more of a paperwork compliance issue, if you will. And I did a study of all 50 of our states on the duration between relicensure surveys in assisted living, and the average was 19 months. So I think we've struck a pretty good balance of saying, if you're a good provider, if you've had a good previous survey, then 24 months. If there have been some issues, some serious issues, 12 months. And of course, I'll remind you that the Cabinet has full authority to go in on a complaint at any point in time, and also has full authority to go in once, twice, however many times they need to verify that the corrections were timely made during that cycle.
I'd like to invoke the privilege of the chair here. I'd like to hold questions until all the presentations have been made, but would like you to clarify your statement about due process. I think you cover that too generically to rank and file people like me. I'm not really understanding what that issue might be.
Very good, Senator. From our perspective, we carefully built in going forward additional protections that the Cabinet will oversee when there's a new applicant, when there's someone coming in for a new building that has not been previously certified as AL or assisted living or licensed as personal care with a dementia care unit. When they apply for licensure, excuse me, the Cabinet for those new providers will look at education of ownership and management. They will look at experience in that realm. They will look at statutory and regulatory compliance, whether it's here or in another state. And then if they deem in the Cabinet's judgment that that applicant has insufficient good basis, thank you, for being a compliant, successful operator within the realm of dementia care, the Cabinet can make the issuance of a license for assisted living with dementia care contingent upon them agreeing to retain the services of a qualified, and the bill sets out what the qualifications are, a qualified consultant in that arena to hold their hand through that process, to ramp up their expertise, so that hopefully there's an excellent compliant experience for that provider, but most importantly for those residents. In the case of existing, which is where the remaining issue has been with the Alzheimer's Association, they have wanted existing providers already having been already having and operating either assisted living or personal care dementia units. They have wanted them treated exactly the same. And that's where I come to due process, in that the state has had the authority all along and continues to obviously, to revoke a license if it's a bad operator, to sanction. They've had full authority to do that if there's a significant problem. The fact that they are, if this bill passes, that they would automatically then bridge over, subject only to the cabinet taking a strong look at the physical plant, make sure it's safe and in compliance. They'd otherwise be grandfathered in, if you will. And we look at that and say, if they were a bad provider, frankly, their right to continue doing business should have been taken. And that relicensure is not the place to be saying if there's a bad operator out there, then they should either not be given a license under this new license structure, or should be made to go to great expense to not only go through the licensure process again, or to retain a consultant. So that's our issue with it, Senator. Does that?
All right. Thank you. Appreciate that.
Yes.
Is there any other testimony?
Briefly. The other issues with the cabinet that we were able to, or concerns they expressed, this committee sub increases from 1 year to 7 years, the period after which a license revocation before an applicant with substantially the same ownership could come back and obtain relicensure of that building. We had 1 year in there, cabinet wanted 7. Thankfully, that's been in assisted living and licensed personal care an exceedingly rare situation where the cabinet has revoked a license. And we looked at that and said, we're not all about protecting someone who is not a good operator. And so we said, fine, 7 years. And should they sell the building or should they substantially change ownership within their group, they could come back sooner. And then another change in the committee sub is requiring that in the event of an emergency, a provider gives priority assistance with sufficient staff to a resident who needs hands-on help to ambulate. You'll recall that in the pre-filed bill, it expands from no staff assistance with ambulation to one person staff assistance. And the cabinet was fine with that. But they, in our estimation, correctly raised to us, wait a minute, we're okay with this expansion in order to help people age in place, etc. However, what's in the bill to sufficiently protect those people, because they're going to have a harder time exiting a building in the event of an emergency? They were right. We built that in. Additionally, the cabinet had also raised the issue about licensure survey and what they are not licensure survey, I'm sorry, the ability of the cabinet to conduct a complete initial licensure survey before licensing a new applicant. And we clarified that, made that very clear. Last thing is that the Kentucky Justice Association approached us a few days ago and had a couple of questions, raised one concern, and sought clarification that a licensee has responsibility for operation of a facility. Language related to that, we were able to work on together and resolve that issue. And my understanding is the association was fine with that change. Those are the significant changes in the committee sub, Vice Chair Meredith.
Thank you. Excellent job.
Thank you.
Senator Alvarado, you have any additional testimony?
So we've heard this in the interim in detail about the original bill, and again, I've got a whole summary, but I think Mr. Lee kind of covered a lot of the material that's in there. So a lot of input has been brought in. Some of you have received some emails. There was one in particular that I think is erroneous that we've received about making sure that that there's a process for people to make sure that they have training requirements, people with dementia. We passed Senate Bill 61 last year that had to do with home health. I think that was your bill, Senator Meredith, and bill that was passed that required the cabinet to set up regulations. On Monday, we had Administrative Regulation Review Subcommittee where they proposed their regulations, and I think all of you should have a copy in your packet of 910-4010, where an amendment was made, and the wording for that is this administrative regulation establishes the process for submitting curricula for cabinet approval that will meet the minimum training requirements for direct care staff serving individuals exhibiting symptoms of Alzheimer's or other dementias. It applies to provider agencies. And in the list of that provider agency, it has assisted living communities that employ directly or by contract aides or other non-licensed personnel whose work involves exclusive contracts. So you've gotten some emails saying that we want that included in the bill. We passed a bill last year that required the cabinet to set up regulations, and that regulation's been established. So it already covers that. So again, I think a lot of the things that we've heard from a lot of the different agencies has been put into the sub. A lot of work's gone into this. Looking forward to this and kind of modernizing really our system of personal care and assisted living facilities in Kentucky and helping people really. I mean, you've heard lots of stories of people who might be in one of these who perhaps develop a terminal condition, want to have hospice services. They have to move from their homes into another setting to be able to get that. This allows for a lot of those folks to stay in place and be able to do that. So I think it's a needed bill, and I would look for everyone's support as well. Thank you.
Thank you. Senator Berg, you have a question.
Yes, thank you, sir. I have a couple questions. I read through this entire bill again, and I'll be honest, as somebody who's had a lot of personal, familial experience with the long-term care process, I still, and as a physician, I still have confusions. And so I'm going to ask just a couple of questions, and I hope you bear with me, sir.
I'll try.
First of all, do the categories of personal care, assisted living without dementia, assisted living with dementia, do these meet some sort of national nomenclature? Is this a nationalized standard, or are we making up our own terms here?
There's not a nationalized standard. In terms of... I heard two questions. One is a nationalized standard, and second is, are we making up our own terms?
Right.
We're not making up our own terms. What we're doing in Kentucky with this bill is aligning with virtually every other state. We have been the outlier now for years with having a strictly pure social model of assisted living where it was illegal, is, as we sit here today, illegal for an assisted living provider to directly deliver any health services, no matter how basic. That would include a staff member, for instance, clipping someone's toenails. A podiatrist has to do that because under Kentucky law, as interpreted by the cabinet, that's an example of a basic health service. Not the taking of the blood pressure, Senator, but saying anything more than, here are your results. In effect, do with it what you will. And administration of medication. All we can do currently is assistance with self-administration. And now under licensed personal care, we've been able all these years to deliver basic health services. And that's all this bill does. It essentially merges licensed personal care, apartment style for the kinds of residents that you see in assisted living, where basic health services can be delivered already with assisted living, but under the name assisted living going forward, which puts us with virtually every other state.
So for clarification, my mother was in an assisted living facility with memory care.
Had a distinct part, secured memory care unit.
Never, 15 years with Alzheimer's, she was never, ever put in a secure unit.
Okay.
She lived among the assisted care residents assisted care with memory care, but they provided medical care. So they were under which category under the new?
When you say they provided medical care, I assume you're meaning health services and.
They delivered her medications. They took her blood pressure. They ran IVs when necessary, and hospice could come in if wanted.
Then they had to have been, and it was in Kentucky.
In Louisville.
Okay. They had to have been, assuming they were, and I'm sure they were, your mother wouldn't have been there, Senator.
Oh, you don't know, because this is such a confusing business.
They
And
had
that's
to.
my concern, guys. My concern is I'm educated. I'm a healthcare provider.
Yes, ma'am.
And
Yeah,
I was
yes,
not
Senator.
able to navigate this system successfully for my own parents.
Well,
this is my concern.
That points out the general confusion in the public, and this bill really does a great job of doing away with that by blending licensed personal care, and I've got to assume that that facility was licensed personal care. And when we say, or I guess Senator Alvarado talked about hospice, it's not that hospice isn't permitted in licensed personal care currently, but there is no provision if someone moves beyond mobility criterion. There's no provision in current law for them to be able to remain in their home in that licensed personal care facility. This bill changes that. That right has already been there the last 11 years in assisted living communities, thankfully, and it keeps that. All I can respond is to say if they were delivering health services, they must have been a licensed personal care facility, not assisted living. They may have sometimes used the term assisted living, but
It's on their board when you drive up. It says assisted living with memory care.
all I can do then is to say that speaks of the public confusion on the issue. And there have been some providers over the years that have perhaps confused the issue itself.
Right. That's my concern. My concern is that this is so significant of an issue
It
for
is.
those of us who are trying to keep our family members safe. And I'm a little concerned. And first of all, I want to applaud the senator from Clark because I think this is so important. This is something that needs to be done, something we should be doing. I am just a little concerned, guys, that the foxes are watching the hen house. Because I sort of see foxes at the table, and that's nothing personal. But I want to make sure that we are protecting those families who trust these providers to take care of their family members to the best of their ability. And I can tell you my personal experience as a healthcare provider was that did not happen in an excellent facility where I don't blame any individual person. The system was not good. The system was not set up. So here's my question, my real basic, I have a lot of issues, but my basic question.
Senator, is this your second question then?
This is my second question, sir, and this
Then we'll have to
can be
move
my
on
last.
afterwards. We still
This
have a
can
lot
be
of
my last.
territory.
Oversight. Existing facilities. I understand new facilities coming in. They have to meet the requirements. They get every other year surveys if nobody's going to die, and once a year survey if somebody's at imminent risk of death. Don't like the language. I would like to make sure that in there somewhere, if you find, if you have a survey, you find somebody's at imminent risk of death, that gets corrected, and then they get on a 6 month and then a year. But that's okay. What I don't understand.
That's absolutely the case under this bill
Right.
and under current law. That
Right.
got
What
to
I
immediately
don't
be
understand is
corrected.
the existing facilities, like the facility where my mother was at.
Mhm.
Walk me through what they have to do to meet new requirements.
Okay. An existing assisted living community or licensed personal care community with a dementia care unit. Is that
I would like for all three of them, honestly,
okay?
because it's
Very good. The under this committee sub, what would happen is an existing would have a review by the cabinet before being relicensed as an assisted living community with dementia care. And that review, in the case of an existing, where they've been operating and have been in sufficient compliance that they hold a license or certification if they're assisted living, that would take a strong look at the physical plant. And then their normal review process would, the complete survey would be done on that periodic basis. And again, I'll remind you, the average duration for assisted living across the country is 19 months. We went with 12 as, frankly, an additional reason for providers. Not that I think we need it, but as an additional reason for providers to strive to be totally compliant. And but in the case of where there have been significant concerns in the preceding cycle, then it would be every 12 months rather than every 24.
and every facility that's currently existing will eventually have to fall under one of these categories.
Absolutely. Absolutely. This does nothing to, it doesn't decrease in any way, shape, or form the oversight of the cabinet. As a matter of fact, it's up to the cabinet under this bill to pick which regulatory agency. Right now, and that's somewhat of an additional confusion point, it's Office of the Inspector General for licensed personal care, and it's the Department for Aging and Independent Living for assisted living. This leaves up to the cabinet to decide which regulatory agency would do that oversight. My best guess, and it's more than a guess, I think, based on conversations with the cabinet, but my estimate is that because in, I believe, every case, those entities that do not deliver, that are not permitted to deliver health services are regulated by the Department for Aging and Independent Living, and those that are permitted to deliver health services are regulated by OIG. I would assume that the cabinet's choice will likely be OIG to do all of the surveys over all of the facilities that would fall under this.
So I think you could make an argument that regulatory oversight is enhanced by this bill in a significant way by bringing assisted living under the purview of the Office of Inspector General, who is an ongoing regulatory agency that has regional offices throughout the state, a team of trained inspectors. I think it's going to only enhance regulatory oversight, and that was certainly our goal.
Sir, could I be permitted one more question?
I would appreciate if you'd allow me to. We have two other folks who have asked to present questions, and if time allows, I'll come back to you. I'll promise you that. Remotely, Senator Carroll has a question, comment. Senator Carroll?
Yes, Mr. Chairman, thank you very much. Senator Alvarado, you're aware that the last few years I filed a bill related to assisted living and protection of the residents within those facilities. And it appears that this bill addresses some of the components that were in that piece of legislation, but there are a couple things that I want to get clarification on. And the first thing is I understand that there will no longer be the ability for an assisted living facility to avoid sanction simply by extending the process. Has that been eliminated?
Yeah, I think right now what you have is assisted living facilities are under DAIL, or the Department of Aging and Independent Living. So this is bringing it under OIG. That's what this does. I've heard from one or two operators that are upset about that. They like to be under DAIL. But this brings everybody under the Office of the Inspector General, which we know is a little bit of a different tier of review and oversight. So I think from that perspective, again, people are going to have the same subject to review. Right now, all nursing homes, as we know, because again, we had this confusion that people are out there, they don't know what is an assisted living facility, personal care home, nursing home. Nursing homes are all subject to OIG for review. This brings everybody under OIG for review. So it's going to have, they're going to have to answer that same regulatory body. If there's any kind of an investigation that takes place, OIG would go in, take a look at the facility. If there's a complaint right now from someone, they would have to go through Dale for those facilities. So this is going to bring them underneath that regulatory body, which if there's concern about, hey, do people have a chance to answer that? We're also bringing the Ombudsman Office, which is a group of advocates who are looking at a lot of these. It expands their purview for that to be able to come in. This is an agency that's federally funded. We don't have any oversight over the Ombudsman Agency, often composed of volunteers. But folks that can go in are supposed to be problem solvers and to help coordinate some of the care if there's concerns or issues from residents. These are assisted living facilities. Personal care homes don't get any federal funding, no state funding. These are private pay individuals who are basically in a private setting. So we've got that organizations involved. We're going to have OIG involved overseeing a lot of this. So I think from that angle, there's going to be more oversight.
Okay. And the other component had to do with background checks for owners and employees, directors of these facilities, where those who had committed, been convicted of certain crimes would be ineligible, as it is with the long-term care facilities. And I know there's been some resistance with that stipulation from at least one of the associations. Is that a possibility for an amendment? Would you be amenable to that addition?
I mean, I know that we filed that bill as well. I know the Senate's passed that bill in the past. If it's my understanding, I believe we've voted that.
The Senate did. It passed out of committee in the House, and it did not make it to the floor.
Mm-hmm. And so I know that you filed that bill as well. I'm not sure if it's something we can discuss for sure. I mean, as far as a possibility, but we'll probably take it up with the group. I mean, when you get a bill like this, I think members have to understand this has been about over 2 years in the making. And so you have a lot of groups that have come together to agree. Just to get the base bill was kind of a Herculean effort. And then from there to get other groups involved to ask for other additions. The sub is a product of that not only did the other groups come with their requests, but then also the core group all agreeing, because it's not just one agency. There's 3 different agencies that are involved in this. They're discussing it. So I think that's something we can discuss. But again, it's going to probably take a big consensus, the risk being that the whole thing falls apart. So I'll be happy to discuss that with you because I'm supportive of that measure. Senator Carroll, I know you've, and it's something I think we probably want to consider passing again in the Senate, and hopefully it'll get all the way across the finish line, but can definitely discuss it.
And I appreciate all your work on this and all the efforts to make these facilities better and to offer greater services for our people. So the work is very much appreciated. Thank you, Mr. Chairman.
Thank you, Senator Carroll. Hope you're doing well. Senator Givens?
Mr. Chairman, thank you. And in the presentation, you mentioned that the cabinet had some suggestions, suggesting changing of 1 year to 7.
Yes,
and
sir.
also your cabinet suggestion that you acted on of ambulatory in case of fire and those protections around that concern. Did the cabinet have other suggestions?
They did have some others, and we certainly communicated with them concerning those. Some of them we didn't necessarily agree with. We probably the biggest example I can think of, Senator, is in the case of Type A and Type B citations. Those are essentially an element that comes straight out of federal law related to Medicare. Medicare isn't applicable. CMS isn't applicable to licensed personal care or assisted living in Kentucky because there's no Medicaid waiver. There's, as Senator Alvarado said, it's all private pay. And while Type A and Type B distinction on violations, on citations with fines have been applicable to licensed personal care, they've been used very, very little by the cabinet. And we simply looked at that and said, even with providing for a provider to be able to deliver basic health services at the level that is being done in licensed personal care today, it's the lowest acuity level that we have in Kentucky. And so the risks of real problems, real risk for residents is significantly higher in a skilled environment where much broader array of skilled services are being regularly delivered and where CMS rules do apply. So that was one issue where we just thought Type A and Type B with civil monetary penalties probably didn't need to apply at this level, and they haven't applied for 22 years in assisted living. I'm not going to necessarily be able to remember every single issue that was discussed, Senator, but that's the biggest one that quickly comes to mind.
Good. Thank you for that. And Mr. Chairman, if I could briefly follow up.
Briefly.
Thank you. The violations concerned me some as I read the language. I appreciate the change from the way the bill was originally filed to the sub, because under the original file bill, there was some language that was very restrictive as it related to the ability to impose civil penalties. Very restrictive language. Still somewhat restrictive in the sub, but I don't have issues with that.
And that did change. We
I
did
appreciate that,
come
yes.
the direction
Yes.
of the cabinet
And
on that issue.
You
did.
You came in the direction of the cabinet.
Yes.
That's well worded.
We did.
And purposely so, but understood. Now, thank you also for meeting with me over the course of the last few days and having these conversations. And I hold this chart up because this chart helps me to understand some of what we're doing, and thank you for that again. We're moving voluntarily those that wish to move, because as I understand the language of the bill, if you still wish to stay in this assisted living community space with your current situation of not offering medication, you can still choose to do that.
You can, unless you have a dementia care unit. And if you have a dementia care unit, you must, under this committee sub, under the pre-filed bill, you must deliver basic health services to the residents of that dementia care unit. And what forms the basis for that removal of choice from the provider is the strong belief that a social model dementia care unit is not what we need, is not what the residents on that unit need, because they are the most frail of the frail that we care for,
Sure.
and they are the ones that are least able to directly communicate their problems, their needs with their healthcare practitioners.
Excellent explanation. So in my layperson's mind, we're permitting the move from this category to this category. Not exactly, but to a layperson, that's what we're permitting to happen.
Mm-hmm.
My question is this: as these entities that are in this category choose to move over into the personal care space, are the violations the same as they are currently today, stronger or lesser as it relates to the cabinet's ability to impose penalties?
They are stronger because currently,
As long as they're not lesser, I'm fine. If you're telling me that the move...
they are equal to or stronger in all
Excellent.
cases.
In making the move, I simply don't want to hear you, and you've been very frank with me. Thank you for that. If in making the move you've crafted legislation that also lessens the burdens of oversight and penalties, then I have concerns. Thank you for that. That's all I need, Mr. Chairman.
Thank you.
Thank you. And we do need to move on. Senator Burke, I know you have additional questions, but we are really operating a terrible time constraint. We have two more bills that we need to hear, and I want to make sure we treat those people fairly. I would encourage you to follow up with Senator Alvarado. You understand this is a process, but we do have one other person who wants to testify. Those of you that are here, I'd appreciate if you'd hang around in case there's any questions after this testimony. But Ms. Mackenzie LaGoria has asked to speak on behalf of this bill. Thank you. Ms. LaGoria, if you could step forward, please. And again, because of our time constraints, I'll ask you to be as brief and succinct as possible. Thank you.
Thank you, Vice Chair Meredith, and yes, I will be brief. While I pull this up, my name is Mackenzie Longoria, Director of Public Policy for the Alzheimer's Association here in Kentucky. Chairman Alvarado, members of this committee, I thank you for allowing me to speak briefly today regarding Senate Bill 11. I am here as a representative on behalf of 255,000 individuals living with dementia and their caregivers throughout the Commonwealth. As of the start of this meeting, and still, unfortunately, the current iteration of this bill is one that the Alzheimer's Association must oppose. Since this major restructuring to the assisted living system in Kentucky was first discussed and proposed, the Alzheimer's Association has worked in good faith to seek reasonable changes to this bill that would protect people living with Alzheimer's and dementia. I must note that we are very appreciative of some changes that have been made in a prior draft of the bill that we have seen. Specifically, however, the association has sought to include dementia training in all assisted living settings and to ensure uniform standards across the industry in the provision of dementia care. Since the beginning of the development of this legislation in early 2020, the Alzheimer's Association has clearly communicated the importance of these aspects of any bill put forward to reform assisted living, including at a hearing during the interim in October. Unfortunately, we have not been met with the same good faith from the industry representatives. In an effort to find a reasonable compromise, the association approached the industry with an offer to drop our demand for dementia-specific training in the regular assisted living setting if the uniform standards were applied to all assisted living communities applying for dementia care licensure. We offered to make this major concession to meet the industry in the middle and to get to a place with agreed language. Unfortunately, our offer was ignored, and we have not received any response from the industry other than what was just presented at the table this morning. Further, I have not seen the committee substitute, and I do not know, at least I have not seen with my own eyes, what changes have been made. Importantly, the creation of a new assisted living community with dementia care license is incredibly flawed in this bill. The bill lays out several requirements that a facility must meet before being issued a license, as we heard, including addressing education and experience in managing residents living with dementia. This section represents some of the absolute best practices of the association, but these critical sections apply only to new facilities. Existing dementia units in operation of the effective date of this act are grandfathered into this newly created licensure system without having to meet these important education and experience requirements. This is unacceptable. Why should some assisted living facilities and personal care homes that will be absorbed not be held to the same high standards just because they're already in existence? The answer to that question, unfortunately, at this point in time is because the industry is pushing this bill and it is not ethical. And frankly, it prioritizes profits over resident needs. Our current assisted living system is not perfect, and the association recognizes that it is past time to move away from a certified social model only system. We support the creation of this two-tiered licensure system, but replacing our out-of-date system with a new licensure that appears to protect residents while really shielding existing facilities from equal standards is wrong. We have a chance to create a new and better model, but it must protect residents and staff in all settings. And the current draft, unfortunately, does not achieve these important priorities. As we have stated over and over again, the association wants to be in a position to support this bill and work together to improve the assisted living landscape in Kentucky. However, the current iteration is not one that we can support as representatives of hundreds of thousands of Kentuckians impacted by Alzheimer's and dementia. We are asking the members of this committee to oppose this current iteration of the bill so that we can work together to create parameters for assisted living licensure that enables the industry to supply critical living services that they excel at, while also protecting the needs and safety of all residents. I will close with one final thought. I was in the cafeteria yesterday getting some lunch, and I handed my card over to the cashier, and on my card it says Alzheimer's Association. This woman looked at me and just said, "Alzheimer's, my mother died from dementia." I said, "I'm so sorry." And she said, "Do you know what the worst part about this disease is?" And I said, "No, I don't." And she said, "I lost my mother twice. I lost my mother when she forgot that I was her daughter, and then I lost her again when she passed away. I can't prevent anyone from having to lose their loved one twice, but I can do my job, and my job is to at least be a voice for those people and to at least fight on their behalf so they can have the best quality of life that they deserve, because they still deserve that quality of life whether they remember that you're their son or daughter." Thank you very much. I appreciate any questions that anyone on the committee may have.
Thank you. Any questions, comments? Senator Nemes.
Yes, I might be a little bit confused if you clear this up. Are you against what is in the bill, or are you against the bill because it doesn't have something additional that you want in it?
I am against this grandfather provision that we have been speaking of specifically. If this grandfather position were to be removed and we agreed that all facilities, not just new facilities, should be held to the same standard, I would be more than happy to support this legislation.
Thank you. Senator Alvarado, please be brief.
Thank you, Ms. Longoria. Listen, I like you personally. Those comments are insulting to me. I'm a provider. I'm a doctor. I devote my life currently to taking care of people in nursing homes that have dementia. To imply that this bill that has my name on it is for the sake of profits and not for making the betterment of people is an insult to me and to the people that take care of a lot of these folks. The Alzheimer's Association was involved in this process early on. You had 20 requests, 20 plus requests. All of those have been incorporated for one. And if you're saying, I don't have my full 20, I've only got 19, I'd rather have the whole bill die, is insulting. It's not how Frankfurt works, I hate to tell you. I mean, 20 things have been requested. To say that you were not included in this process is not true, factually incorrect. You were involved in this process early. We sought requests. 19 of the 20 things that you've requested have been incorporated into this bill. And to say, well, I didn't get my 20th, so I'm going to oppose it, or your organization, is an insult. Frankly, to me, and to imply this is being done for profits is an insult. I don't do things for profit here. People know me. I'm pretty passionate about healthcare, and I'm pretty passionate about being a doctor. I take a lot of pride in when someone says you're putting money before patients is an insult to me. You can ask all of my colleagues. I've had those discussions behind closed doors. I don't do things that way. This is to improve the care, to modernize Kentucky's healthcare system, and to say, hey, I'd rather have 0% than 95%, I think is a bad approach to healthcare. Mr. Chairman, I would ask for a vote on this measure. Thank you.
Is there a motion on the bill? Motion by Senator Nemes. Is there a second? Second by Senator Wise. All those in favor of the bill will vote aye. All opposed will vote no. Clerk, please call the roll.
Senator Rocky Adams. Aye. Senator Byrd.
I'm going to vote aye and would like the chance to explain my vote.
Please be brief.
Thank you, sir. I will try. I think there's some really good things in this bill. I think this is a system that desperately needs to be updated. I think this bill personally is extremely confusing. I can't even figure out where my own family members would fit in these facilities, and that bothers me a little bit. The oversight bothers me. So I am going to vote yes. I'm going to reserve the right to vote no on the floor, because I really need to see that some of the things in this bill that concern me are addressed. Thank you.
Thank you.
Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howell.
Aye.
Senator Kerr. Senator Meredith.
Aye.
Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye. The matter is reported favorably. The final vote is 9 yeses, no zeros, and no pass votes. Thank you very much. It'll be reported favorably to the Senate floor. The next item on the agenda is Senate Bill 55. It's an act relating to certified stroke centers. The sponsor is Senator Don Douglas. Dr. Douglas, if you'd like to approach the table, I think we have also a guest. If you'd like to both introduce yourselves for the record and begin your testimony whenever you're ready.
Thank you, Mr. Chairman, and good morning to the committee. I'm Senator Donald Douglas from Jessamine County. I represent District 22. We're here this morning to introduce and help explain Senate Bill 55, that is the Stroke System of Care Bill. The bill introduces a way to further define, or I guess I could use the word categorize, the different levels of centers of care available to treat our stroke victims. Ms. Shannon Smith is here today with me from the American Heart Association, and she is here to help further discuss the purpose of the bill and to help me answer any questions.
Thank you, Chairman Alvarado, Vice Chair Meredith, members of the committee. I am Shannon Smith with the American Heart Association, and this bill adds a level of care to our current stroke systems of care, including thrombectomy-capable centers. Currently, we have 3 levels of care in Kentucky. We have acute, primary, and comprehensive. This includes thrombectomy capable. This is a procedure, a surgical procedure that removes blood clots from large vessels or organs. Most of the time it's arms or limbs. It can be organs. So this includes thrombectomy capable centers, and then it just clarifies within the language that it says primary and it changes it to certified because primary is a level of care. So those are the only changes and updates. And if there are any questions?
We have a motion on the bill. We have a second. Or any questions from members? If not, Madam Clerk, please call the roll.
Senator Rocky Adams. Senator Byrd.
I'm sorry, I'm going to pass. I don't understand why this is needed, but get to me later. Thank you.
Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howell.
Aye.
Senator Kerr. Senator Meredith. Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye. Very good. The matter passes favorably with 8 yes votes, 1 pass, and no votes. So congratulations, Dr. Douglas. Now you will be seeing a lot. You're going to be seeing more of you because you have a next bill as well. But congratulations. I know this is your kind of first bill being presented. Thank you very much for your testimony.
Thank you, Mr. Chair and committee.
Next, we've also got Senate Bill 56, which is an act relating to opioid antagonists designed to reverse the effects of an opioid overdose. The sponsor is also Senator Don Douglas. And if you have any other guests which are joining you, I think there's some that might be joining here in person or by Zoom. I think they're online. I think we have Dr. Phil Skolnick, who's the Chief Scientific Officer for Opiant Pharmaceuticals. Dr. Skolnick, are you online?
Yes, I am. Can you hear me?
Yes, if you could introduce yourself officially for the record would be helpful.
All right. Thank you for having me today, Chair Alvarado and Vice Chair Meredith. My name is Dr.
If you could introduce yourself for the record, just your name and your title.
My name is Dr. Phil Skolnick, and I'm currently the Chief Scientific Officer at Opiant Pharmaceuticals.
Very good. Thank you, Dr. Douglas. However you'd like to handle it. If you'd like to start first, Dr. Skolnick, whatever's easiest for you.
I would like to start first, Mr. Chair. I'm here to introduce this bill. This is Senate Bill 56. I call it the Opiate Antagonist Bill. The opiate antagonist is designed to reverse the deadly effects of opiate overdose, whether these overdoses occur in the hospital setting or in the community setting. Now, naloxone has been the standard, and this is what our first responders have used for many years, and it has played a critical role in saving many lives. It in fact, is named specifically in the legislation. The bill I'm introducing today is to expand the language to allow the inclusion of more and newer opiate antagonists to come to market. Dr. Phil Skolnick is here. He is the Chief Scientific Officer for Opiant Pharmaceuticals, and he'll help explain the need for some of these changes that we are asking for and to help answer questions.
Dr. Skolnick, go ahead and proceed.
Thank you. By way of background, I led the NIH team that developed the concentrated naloxone nasal spray. This resulted in the FDA approval of what is now known as Narcan nasal spray. I've spent more than 32 years at the National Institutes of Health, most recently as the director of the National Institute on Drug Abuse's Division of Therapeutics and Medical Consequences, where we focused on the development of pharmacotherapies for addiction. I am testifying today in support of Senate Bill 56, updating references to naloxone in the Kentucky statutes to be more generic, allowing for any FDA-approved opiate overdose reversal agent to be used. Biomedical investigators, including my colleagues and I at Opiant, are working to develop new reversal agents in response to a request by the leadership of the National Institutes of Health to, quote, work with private partners to develop stronger, longer-acting formulations of antagonists to counteract the very high-potency synthetic opioids that are now claiming thousands of lives each year. As both the number of opiate overdoses and opioid-related deaths continues to rise, public policy must continually be updated to ensure that innovative rescue medications, such as rapidly absorbed, high-potency, long-acting opiate antagonists, can enter the marketplace and be made available to the medical community, first responders, and EMS, as well as Kentucky citizens. As written, Senate Bill 66 will not allow people in Kentucky access to all reversal agents. The downstream consequence could include, but not limited to, confusion regarding which reversal agent can be utilized. Simply stated, in light of the rising number of opiate overdose deaths in Kentucky, we need all the available tools in our toolbox to combat this epidemic. Good Samaritan and standing order laws must be updated to be molecule agnostic. These updates are essential to allow anyone to use next generation FDA-approved reversal agents, regardless of their molecular nature. The current language in the Kentucky statute restricts Good Samaritan and standing order access to next generation opiate antagonists. Standing order legislation has been put in place to provide increased access for anyone who wants a reversal agent on hand simply by walking into a pharmacy. Good Samaritan legislation was intended to limit concerns of risk and liability when assisting those in dire need of help. If these two essential components of the Kentucky statute are not updated with molecule agnostic languages that applies to all FDA-approved reversal agents, this will limit access to highly effective, potentially life-saving medications in an area that desperately needs to be expanded. When the statute was initially written, naloxone was the only FDA-approved molecule to reverse overdoses. Its authors could not have anticipated either the dramatic rise in opiate overdose deaths due to synthetic opioids like fentanyl, or the development of innovative alternatives to naloxone. I believe the intent of both Good Samaritan and standing order provisions was to allow for access to and protections for anyone working to reverse the effects of an overdose. Opiant and other organizations are in the process of responding to the NIH's request for developing stronger, longer-acting formulations of opiate antagonists. Multiple organizations have begun working on developing reversal agents utilizing a molecule called nalmefene. Should these products be approved by the FDA, based on already existing and newly emerging science, nalmefene will prove to be a powerful tool in the battle against the opioid crisis. Given that Kentucky's current standing order and Good Samaritan statute applies only to naloxone products, if this update is not made, individuals in Kentucky will not be protected under the state's Good Samaritan law if they use nalmefene to reverse an opiate overdose or another FDA-approved reversal agent, and they will not be able to access it under the state's standing order. According to provisional data released by the CDC, there were over 100,000 drug overdose deaths in the US in the 12 months ending in April 2021. This represents an increase of over 28% from the year before. Of these overdose deaths, the CDC estimates more than 75% were due to opioids, with the vast majority being attributed to synthetic opioids like fentanyl. According to CDC overdose data, in the 12 months ending May 2021, Kentucky had an estimated 2,267 deaths due to an opiate overdose. This is a significant increase from the previous year's number of 1,647, which represents almost a 38% year-over-year increase. These numbers are staggering and likely reflect the increased misuse of high-potency synthetic opioids like fentanyl. It is also important to note these deaths in Kentucky have shown a disproportionate shift towards affecting the African-American community. According to a report by Dr. Slavova and Quisenberry at the University of Kentucky, death rates from opiate overdoses among African Americans rose 57% in Kentucky from 2019 to 2020. We must make certain that underserved communities have access to all available reversal agent with adequate Good Samaritan protections to reduce these statistics. Recently, NIDA reported 1 in 20 people who present in an emergency room with an overdose die within the next 12 months of an overdose, and that 2/3 of these individuals die from subsequent opiate-related overdose. This is a really startling statistic. Based on evidence from states such as New Mexico and New Jersey, expanded access to opioid reversal agents has been a contributing factor in decreasing overdose deaths. Increased access to medications like opiate reversal agents and increasing education on the associated risks of opioids have been demonstrated to curb the number of opiate overdose and reduce the number of overdoses in general.
Dr. Skolnick, I'm going to interrupt you just for a moment. We have a motion on the bill. Is there a second? We have a second. I think the basics of the bill is effectively that we're getting rid of a specific name of a drug in the bill and replacing it with a generic class of that drug is within to expand the ability to be able to treat this. We appreciate that. I know you've got a lot of material. We do have a tight schedule, however, and we do have a motion in a second. We do have one question from Senator Berg.
Please.
I will withdraw my question. Thank you very much.
Thank you very much. All right. If there are no other questions or comments, Madam Clerk, please call the roll.
Senator Rocky Adams. Aye. Senator Berg.
I with thank you, sir, very much. This is a no-brainer and should be done. Thank you.
Senator Carroll. Senator Givens. Senator Harper Angel. Senator Howe.
Aye.
Senator Kerr. Senator Meredith.
I'll explain my vote briefly, please.
Please proceed.
I want to thank our newest member of our caucus, Senator Douglas, for bringing this. It's a great bill. Sad commentary on society that we live in today, but been greatly needed. So I appreciate you doing that and appreciate the testimony this morning. I vote aye.
Senator Nemes.
Aye.
Senator Wise.
Aye.
Chairman Alvarado.
Aye. The matter passes with a vote of 9-0. Congratulations. I do, before we conclude, Dr. Skolnick, just a yes or no answer. It is my understanding that there is a drug in the pipeline through Opiant to treat marijuana overdoses. Is that correct?
That's correct.
Thank you very much, sir. I appreciate that. That should say something about that consideration. Is there any other matters to come before the committee? If not, we stand adjourned. Thank you. Reading on the side.